We now move to our next lecture.
I'm very glad to invite Dr. Indrani Hemant Kumar to come on the dais. She is going to talk on relatively recent and important topic, which is brain death diagnosis and principles of organ preservation. May I call upon Dr. Ullas Misar, Dr. Vikas Karne and Sunita Shinde Madam on the dais to chair the session.
I request our chairpersons to introduce our speaker, Dr. Indrani Madam.
And welcome to this session. Indrani Madam doesn't require any introduction. She has been teacher to many of us, and it has always been pleasure to listen her. She's currently in KM Hospital, and she is mainly into the pediatric anesthesia right now. And she is currently GC member, National ISA, and she has many such accolades to her name. So without wasting time, I hand over mic to you, ma'am. Thank you.
Thank you so much, chairpersons. And my dear friends, good afternoon. First of all, I would like to thank Rupali for giving me this opportunity and the entire team ISA MIRAJ-SANGLI. And it is going to be a big challenge for me to keep all of you awake, alert, and not be obtunded after such a wonderful meal. And that too to talk about something called brain death and principle of organ preservation, where we are going to talk about consciousness. Well, why this is so important? Because a knowledge of brain death is important for all of us. Seriously, because it helps in organ donation and it saves lives. So before we go into the aspects of, without wasting time, we know the normal brain anatomy. It has three main parts, that is the cerebral cortex, then we have the brain stem, and then we have the cerebellum, right? So the cerebrum is the largest part of the brain, and it has got the right and the left hemispheres. And it also has a diffuse network of nerve pathways which connects to almost every part of the brain, isn't it? So the cerebral cortex is involved with consciousness, as I told you, in cognition. It takes care of all the higher functions like interpreting touch, vision, hearing, and not only that, it also is involved with speech, reasoning, emotion, learning, and also control of movements. So all the voluntary movements are being controlled by the cerebral cortex as well as the sensation. Once we talk about the brainstem, we know the brainstem consists of midbrain, pons, and medulla. And the midbrain controls the cranial nerve, third cranial nerve, which is involved in pupillary function as well as the eye movement. Apart from it, we know that the brainstem is the one which is the link between the cerebrum and the rest of the body. So the flow of messages from and to the brain is only through the brainstem. Apart from it, it also takes care of certain basic body functions like respiration, swallowing, heart rate, blood pressure, and consciousness, whether you're awake, whether you're asleep, all of them are being mediated through only the brainstem. So, and we have the pons, which takes care of, which is the seat for the cranial nerves 4, 5, and 6, wherein conjugate eye movements and corneal reflexes are important. I'm specifically taking your attention to these because we are going to check these reflexes. The medulla takes care of the cranial nerves 9 and 10, which is involved in pharyngeal or the gag reflex, as well as the cough reflex, which is the tracheal reflex, as well as respiration. What is death? A diseased person means a person in whom permanent disappearance of all evidence of life occurs by reason of brainstem death, or in a cardiopulmonary sense, that is a cardiac death. At any point, any point of time after live birth has taken place. So, brainstem death, which we are going to check, is cessation of all functions of the brainstem, wherein the proximate cause is known. Please remember, when you are going to sign a brain death, you have to know what is the cause. So please remember, this is one very important thing and is considered permanently irreversible. This is the second important thing. So for one thing, you have to know when you're certifying brain death, you have to know the cause. Second, you also have to know that it is a permanent and it cannot be reversible. So what is the brain death criteria? Brain death is established by documentation of three important points. One is irreversible coma or unresponsiveness. That is very important. Second is irreversible loss of brain stem reflexes. And the third one, cessation of respiratory center function or apnea. And I have actually marked in grey demonstration of cessation of intracranial blood flow, because that is not considered important when you can consider the first three. Only when you cannot do the first three, that is when in certain important conditions like trauma, etc., where you can't do the reflexes, so that is when you can, or even pediatric patients for that matter, you have to demonstrate what we call cessation of intracranial blood flow. Okay, some of the cause of brain death, I'm just illustrating few: cerebral anoxia. This is normal. This is cerebral hemorrhage. Then subarachnoid hemorrhage. Then we can have trauma, meningitis. So the mechanism of cerebral death is a neuronal injury, which gives rise to a neural swelling, that gives rise to a raised intracranial pressure, which again leads to a decreased intracranial blood flow, which in turn incites a neuronal injury. So this is the mechanism of cerebral death. And therefore, here the intracranial pressure is more than the mean arterial pressure, which is incompatible with life. So this is a very important slide, because you need to know the checklist prior to proceeding with test of brain death. One is, as I said, the proximate cause for the unresponsive state is to be known. As I already told you, what are the main causes of brain death, and neurological imaging to confirm the diagnosis. So if you have a patient of trauma, say with hemorrhage, you have to have a CT scan to show that this patient had a hemorrhage. So you need a neurological imaging to confirm that diagnosis. Exclusion of associated medical conditions that could account for unresponsiveness. For example, you can have a patient with acid-base metabolic abnormalities who's obtunded. So you have to rule out any of these medical conditions like severe diabetes. All these can give rise to, acid-base metabolic electrolyte disturbances. So you have to rule that out first. Exclusion of drugs causing unresponsiveness, like sedatives, narcotics, muscle relaxants, and all of them at least should have passed 5 half-lives. So only then you can give a diagnosis of brain death. So you have to rule out a person who has taken or who has had an injection of any of these drugs until 5 times the half-lives of the drug. And the last and most important is the patient should have normal temperature, for which you have to do a core temperature monitoring. So some of those, as I said, the clinical tests, one is to know the responsiveness. So one is coma. So absence of response to a noxious stimuli, with the exception of a spinally mediated reflex, is important. So how you can do it? You can give a painful stimuli in the nail bed, you can give a painful stimuli in the supraorbital ridge, or you can give a painful stimuli in the sternum. So you give a painful stimuli and see if there is a response. Next is absent brainstem reflex. How can you do that? There are various evaluation, there are various reflexes which has to be determined when and especially when the patient has a fixed dilated pupils. So this fixed dilated pupils with absence of cranial nerves should be documented for more than 4 hours. So what are the brainstem reflexes you will do? One is absent pupillary reflex. So that the nerves tested here is afferent, the second cranial nerve, and the efferent is third cranial nerve. Absent corneal reflex. So pupillary reflex, you flash a light and you see for the pupillary constriction. Corneal reflex, you take a cotton bud, try to hit the cornea with it, and if there is no blinking, then you know that there is absent corneal reflex. Then absent reflexes in the face and maxillary region, try to pinch. Absent oculocephalic reflex, that is afferent. So here the cervical spine injury must be ruled out before doing this doll's eye movement. Usually what happens when the head is being moved from side to side, the eye is moving on the opposite side. So there is absence of this doll's eye movement, and that has to be checked. And oculovestibular reflex, wherein you flush in a 50 ml of ice cold saline into the ear. There has to be a nystagmus with a slow component towards the side of injection and in a functioning brain, and this is absent in a brain dead patient. And finally, the tracheal reflex, you just try to stimulate with a suction catheter and try to develop and establish a gag. If that is absent, then we know that the 9th and the 10th nerve is also absent. And the last one which we have to do is apnea test. The aim of the test is to check the integrity of the brainstem. Respiratory center is in the brainstem at high levels of blood carbon dioxide. The prerequisites for an apnea test is: 1, the patient is normothermic, hemodynamically stable. That is, the systolic blood pressure should be at least 100 millimeter mercury, free from sedative paralytic drugs. Oxygen levels on ABG should be near normal, and PaCO2 levels also should be near normal when you start doing the test. Okay. Some of the ancillary tests which for brain death is the 4-vessel DSA, which is the gold standard. As I said, it is being done for pediatric patients and in whom you cannot do the above patients. For example, if you can't do an apnea test, okay, so you can do a 4-vessel DSA if it is not possible to do the other tests. So technician 99 perfusion scan, transcranial Doppler, EEG, CT angiography, MR angiography, SSCP. These are the various options available for brain death. But remember, the first 3 which I said, loss of consciousness, then the reflexes and the apnea test, they are the most important. The first step is to establish if there is an underlying cause for the patient to be brain dead. I also said what you have to look for. You have to avoid anything which can mimic a brain death. For example, patient can be unconscious because of severe hypotension, maybe because of hypothermia or whatever. So you have to rule out those things. Look for confounders before proceeding for brain death verification. This also I have told you. You have to avoid all those medical conditions like hypoglycemia, acid-base abnormalities, and overdosing, narcotic, overdosing, things like that, for which you have to conduct certain tests. For example, you have to do a TOF response in these patients, do an ABG to know the oxygen carbon dioxide levels, do a blood glucose in these patients, and also do a serum electrolytes to know the sodium and potassium levels. So these are the practical tips to know how the next step. That is, next is identify brain death by complete neurological examination. So who does the testing and when? Testing can be done after 4 to 6 hours if no recordable brainstem signs by bedside by the doctors or the nurses, provided all the preconditions which I said is met. Testing is done by any 2 doctors at an interval of 6 hours apart. So who are the doctors? They can be a neurologist, an intensivist, a neurosurgeon, anesthesiologist, or an equally qualified doctor who is certified to be on the hospital brain death panel. Apart from these 2 doctors, we also need to have 2 more persons who are on the administrative side, that is the hospital administrator and the primary physician. So the neurological, as I said, again, this is just a repetition of what I already said. So this is to know the response to painful stimuli, okay? And next is to understand the various reflexes. This is pupillary reflex, this is corneal reflex, this is the gag reflex, this is the tracheal reflex, cough reflex, and this is the vestibulo-ocular reflex. And for apnea testing, I would just to give few tips. Pre-oxygenate the patient with 100% oxygen for at least 15 minutes. Give adequate volume vasopressors to keep the mean arterial pressure at around 70 millimeter mercury. The carbon dioxide rises by around 3 millimeter per mercury per minute of apnea. So be prepared to test for at least 8 to 10 minutes of apnea. So once the 2 specialists complete the test, that is when the time of death is confirmed as the second examination time. So what are incompatible with observations which are incompatible with brain death? If the patient is decerebrating or extensor or flexor motor response to painful stimuli is present, or if there are seizures, then it is incompatible with brain death. We cannot confirm brain death in these patients. However, if the patient has involuntary movement, sudden movement of the hand, which has got nothing to do with the pain, it should not be related to the pain. So if there are just movement of the hand, which are spinal reflexes, sweating, blushing, tachycardia, normotension without pharmacological support, and absence of diabetes insipidus, they are all considered as compatible for brain death. So some of the confirmatory tests, as I already said, generally for children less than 1 year, we do a cerebral angiography, cerebral scintigraphy. EEG is not recommended, and transcranial Doppler is also not recommended. And for radiographic confirmation, if it is only not possible to do the above 3 things which I said, that is facial fractures, swollen eyes, etc., or C-spine fractures, as I said, apnea test is not possible in these patients. Only in them you have to do a radiographic confirmation. Otherwise, trying to do a radiographic confirmation and trying to say that this is brain dead is not allowed. So you should have a reason why you're doing a radiographic examination in these patients. So look at this 4-vessel angiography. If you look at the first, you will find that there is a dense, vascularity all over the brain, and there is a cutoff of the vascularity on the other side. Similarly, if you look over here, if you see that the vessels are filling up to the brainstem, but beyond that there are no vessels in the brain. And the perfusion scan, this is a normal cerebral perfusion scan, and this is a abnormal cerebral perfusion scan. So what is the time to transplant the organ? The lungs and the heart should be transplanted within 4 hours, liver within 18 hours, pancreas within 12 hours, intestines within 8 hours, and kidneys within 36 hours. So we'll come to organ preservation. Why organ preservation? We have to preserve the organ because one is we have to buy time, right? We have to prepare the recipient. The preservation should modulate the cellular environment and suppress the metabolic function and hence the catabolism. And it is achieved with hypothermia or chemicals or drugs, or recently it is being maintained using a pulsatile perfusion of the organs. And organ preservation is also needed because it is a major determinant of a good graft outcome after revascularization in the recipient. What are the types of preservation? As I said, one is cold storage, which all of us are following even till today. But the tomorrow is not going to be just static cold storage. The tomorrow will be a dynamic perfusion, preservation, in terms of hypothermic machine perfusion or a normothermic machine perfusion and oxygen persufflation. So the basic principles of organ preservation is two important dogmas. One is a low temperature preservation, as I said, which is the most common strategy. The low temperature actually preserves the organ because it decreases the metabolic rate of these organs, and it delays any cellular metabolism and any damage to that organ. Next is to have a high potassium solution. Why? The high potassium dogma relies on the hypothesis that as the function of the ionic pumps, the sodium potassium ATPase pump is impaired during the preservation, the intracellular ionic content can be maintained using an extracellular preservation solution with a similar ionic content. That is why we have a high potassium solution. So what are the disadvantages of having high potassium in your preservative? The advantages outpour the disadvantages, but some of the disadvantages which we have to look at is high potassium induces cellular depolarization and accelerates the decrease in the cellular ATP content. What happens is with increase in potassium, the voltage dependent channels such as the calcium channel are activated. So when the calcium channel gets activated, there is vasoconstriction, right? Then the most importantly, potassium concentration about 15 millimole is a potent stimulus for vasoconstriction that impairs organ infusion during washout and reperfusion. And the third important factor determining organ viability is tissue edema. So what happens is there is an inhibition of the sodium potassium ATPase followed by intracellular accumulation of sodium chloride influx, and therefore there is a cell swelling. So there is an increase in cytosolic calcium concentration leading to mitochondrial swelling, and that will start proapoptosis, which means the death of the organ which we want to transplant. So we have to have preservative solution which have high concentration of osmotically active substances. And oxidative stress is again something which we have to avoid, especially during reperfusion. During reperfusion, what happens? Free oxygen radicals are being liberated, isn't it? So then to avoid that, what we do is there is reintroduction of oxygen molecules. So when we give 100% oxygen, we reintroduce the oxygen molecules, and that reduces the dioxygen molecules leading to reactive oxygen species. So there is increase in free oxygen radicals, and that can directly injure the cells by activating as well as by activation of different cellular signaling pathways. So both mechanisms cause opening of the mitochondrial permeability transports, and that can lead to cell death. And lastly, cell membrane integrity, especially the endothelial cells. I give you an example is the glycocalyx in the kidney. Similarly, you have the endothelium in various organs. So integrity of the glycocalyx have to be maintained, that has to be protected, and that is again one important thing which we have to keep in mind. So what are the various solutions which we have been using so far, and what is our future? The first solution which we were using is the urocolon solution for cold storage, static cold storage, as early as 1969, and that has been the mainstay for preserving kidney, liver, and other organs, and we are still using it. It tackles the problem during cold ischemia time, preservation possible up to 24 hours or longer. What is the important constituent of urocolon solution? Is it is isotonic, it has got high potassium, it has got glucose for osmotic concentration. So that is to take care of the edema, and also provide substrate nutrition, phosphate buffer, low viscosity, and it can preserve up to 6 hours comfortably. So this is the various constituent of the urocolon solution. The potassium is very high. You can see dextrose is also there, and the osmolarity is almost near isoosmolar. Next we have is University of Wisconsin solution. What is the difference between urocolons and University of Wisconsin solution? It's almost the same, except for the fact that instead of glucose, it has lactobionate and raffinose for osmotic concentration, hydroxyethyl starch to prevent edema, and in addition, they have added glutathione and allopurinol, insulin, steroids for free radical scavenging and membrane stabilization, and adenosine as a substrate for ATP resynthesis during reperfusion. Next, we have what we call as the Brettschneider HTK solution. What is HTK? It is histidine, which retards acidosis, tryptophan, prevents membrane injury, and ketoglutarate, which is substrate for energy metabolism. This HTK is ideally used to preserve the heart. So, very commonly used in cardiac transplants. So, we have that. Then we have the Perfidex solution for lung preservation. So, this has come lately, and this Perfidex solution is the gold standard for preserving the lung. And it has got piece, apart from all the same constituents which I just told you, it also is supplemented with calcium and thiam, and it has got some pharmacological additives like prostaglandin E1, which causes vasodilatation, heparin, and glucocorticoids in addition. So, lastly, we have what we called as polyethylene glycol. This exerts an oncotic pressure that limits the deleterious effect of edema. That is number one. But what is significant about this PEG is it gets absorbed into the cell membrane surfaces and immunocamouflages, those antigenic sites. And therefore, it gives you not only the protection which the organ needs, but it also gives you the immune protection which the organ needs. So that has come into the market. So PEG probably will be used extensively in future for many of the transplantations. Friends, the supply of organs available for transplantation is already far smaller than the demand. Anesthesiologists should learn to identify brain death to enable more cadaveric transplantation. Newer methods of organ preservation protect the endothelium to have best outcomes from organ transplant surgeries. Thank you so much for your attention. I also would like to, get your attention to, and my appeal to kindly register for IPA 2025, which is going to be held in AFMC Pune, not very far from here. And I appeal to all of you to kindly register. The dates are 14th to 16th. And my sincere appeal to all of you to please register and come in large numbers. And I also appeal all of you to please register for ISACON Patna. And let us all meet in Patna. Thank you very much.
Thank you, ma'am, for extensive and elaborate presentation on the organ donation. I would just like to ask you, just elaborate the apnea test.
Yes, okay.
For the benefit of our students. And
so give 100% oxygen. Before that, you ensure that the patient's blood pressure is normal. Do an ABG electrolytes. The PaO2 should be near normal. The oxygen should be, PaCO2 also should be near normal. There should not be any acid-base abnormalities. You have also checked for other reasons like, the blood glucose should be normal. The patient's consciousness should not be there. So if once you have tested for brainstem reflexes, you have tested for the consciousness, you have tested for all the metabolic, inaccuracies which can happen, which can get missed in a patient, of a brain dead patient, you have to do all that. So give 100% oxygen, ensure that the ABG electrolytes are normal, ensure that the mean arterial pressure is at least 70. You can give fluids, you can give vasopressors, but maintain the mean arterial pressure. So at this point of time, you have to disconnect the endotracheal tube. All right? And you can allow up to 7 to 10 minutes. You have to check wait for 7 to 10 minutes. In between, you have to keep drawing blood for ABGs. Generally, there is at least 3 to 4 millimeter increase in CO2. So, if that is established, then we have a positive.
Whether we should supplement oxygen in between.
Depends upon the patient. If the patient becomes hypoxemic, then you can supplement. Otherwise, that's not a precondition.
Thank you.
Thank you, ma'am,
Thank
for the clear and the crisp lecture. I request chairperson to felicitate madam.
As far as
Sir.
brain death patient,
Sir.
where stands the role of head of the institute, police and lawyer?
Head of the institute?
Police and lawyer, collector, and all this.
No. They
To
have
declare the brain death.
to declare death only hospital administrator.
Where stands the
No,
role?
no
or
lawyer, no
organ-
police. No lawyer and police.
Nothing required.
Okay.
No.
Thank you, sir.
Thank
I
you.
request chairperson to felicitate madam. कोण नाही. Now I request Sudhir Patil sir to felicitate our chairperson at felicitation venue.